Welcome to Pediatric Case Review. Today, we are presenting a comprehensive clinical review on vascular rings in children. We will explore everything from pathophysiology to diagnosis and surgical management. Let us dive into the presentation to enhance your clinical understanding. Our learning objectives are to understand the classification and pathophysiology of vascular rings, recognize respiratory versus gastrointestinal clinical presentations, interpret diagnostic imaging like computed tomography, and understand surgical management principles. We will also review associated genetic syndromes through 16 case-based questions. Question 1. Double aortic arch presentation. A 2-week-old male infant presents with progressive inspiratory and biphasic stridor, respiratory distress, and intercostal retractions. A chest radiograph shows bilateral widening at the aortic arch level with central tracheal narrowing. What is the most likely diagnosis? Option A. Right aortic arch with aberrant left subclavian artery. Option B. Double aortic arch. Option C. Pulmonary artery sling with tracheal stenosis. Option D. Innominate artery compression syndrome. The correct answer is option B. Double aortic arch. This typically presents in the first weeks to months of life with severe stridor. It is the most symptomatic type of vascular ring because it forms a complete ring around both the trachea and esophagus, creating severe concentric compression requiring urgent surgical evaluation. Question 2. Recurrent infections and hyperinflation. A 6-month-old female infant presents with a recurrent cough and 3 episodes of pneumonia in 4 months. Examination reveals a seal-bar cough and hyperinflated chest. Echocardiogram shows the left pulmonary artery arising from the right pulmonary artery. What anatomic finding makes a pulmonary artery sling unique? Option A. Left pulmonary artery originates from descending aorta. Option B. Left pulmonary artery arises from right pulmonary artery and courses between trachea and esophagus. Option C. Complete cartilaginous rings form. Option D. Right aortic arch passes posterior to esophagus. The correct answer is option B. Left pulmonary artery arises from right pulmonary artery and courses between trachea and esophagus. A pulmonary artery sling has a unique embryologic origin. It creates a sling effect around the distal trachea and is uniquely associated with complete cartilaginous tracheal rings, often requiring simultaneous tracheoplasty. Question 3. Vascular ring with cardiac anomaly. A 3-month-old boy has a right aortic arch with aberrant left subclavian artery and comeral diverticulum. An echocardiogram confirms tetralogy of Fallot. What is the significance of finding a 22q11 deletion in this patient? Option A. Explains only congenital heart defect. Option B. Confirms isolated aortic arch anomaly. Option C. Represents common syndrome affecting neural crest cell migration. Option D. Increases likelihood of tracheomalacia. The correct answer is option C. Represents common syndrome affecting neural crest cell migration. DeGeorge or 22q11.2 deletion syndrome is present in 10 to 20% of vascular ring patients. It highly associates with contratruncal anomalies like tetralogy of Fallot. Comprehensive genetic and immune testing is mandatory. Question 4. Selective dysphagia. A 14-month-old girl is a picky eater who refuses solids but tolerates liquids. She hyperextends her head while eating. A barium swallow shows posterior esophageal indentation. Why does this patient have predominant gastrointestinal symptoms rather than respiratory symptoms? Option A. Right arch creates esophageal compression but minimal tracheal compression. Option B. Pulmonary artery sling has been ruled out. Option C. The patient has dysphagia lysoria. Option D. She will definitely develop respiratory symptoms. The correct answer is option A. Right arch creates esophageal compression but minimal tracheal compression. The aberrant left subclavian artery has a posterior course resulting in significant esophageal impact without squeezing the trachea. Head hyperextension is a classic adaptive eating posture, and these symptoms typically manifest after the introduction of solid foods. Question 5. Brief resolved unexplained event. A 4-month-old infant had a witnessed event with loss of consciousness for 15 seconds, appearing mottled and limp. She has a history of baseline stridor. Chest radiograph shows a widened superior mediastinum. What imaging study should be prioritized to rule out a life-threatening vascular ring? Option A. Barium esophagography. Option B. Transthoracic echocardiography. Option C. Computed tomography or magnetic resonance angiography. Option D. Cardiac catheterization. The correct answer is option C. Computed tomography or magnetic resonance angiography. Brief resolved unexplained events can represent critical airway compromise. Computed tomography angiography is the gold standard, offering rapid, high-resolution, three-dimensional reconstruction essential for assessing vascular anatomy and the exact degree of compression in an acute setting. Question 6. Chronic cough misdiagnosed as asthma. A 9-month-old boy diagnosed with asthma at 4 months has had 6 respiratory infections and poor weight gain. Computed tomography shows a left arch with an anomalous innominate artery compressing the trachea anteriorly. What is the most likely diagnosis? Option A, uncontrolled asthma. Option B, innominate artery compression syndrome. Option C, bronchiolitis. Option D, primary immunodeficiency syndrome. The correct answer is option B, innominate artery compression syndrome. This is a classic diagnostic masquerade, often misdiagnosed as asthma. The innominate artery originates more leftward than normal, causing anterior tracheal compression. This leads to impaired airway clearance and growth failure. Patients typically show dramatic clinical improvement following a surgical aortopexy. Question 7. Prenatal diagnosis. A 24-week fetal echocardiogram identifies a double aortic arch. A fetal magnetic resonance imaging confirms bilateral pattern arches. Parents are counseled regarding surgical requirements. What is the current recommended management approach for a prenatally diagnosed double aortic arch? Option A, emergent delivery and immediate surgery. Option B, surgery only if symptoms develop. Option C, surgical repair at 6 to 9 months of age if asymptomatic. Option D, conservative management indefinitely. The correct answer is option C, surgical repair at 6 to 9 months of age if asymptomatic. Double aortic arch has a very high symptomatic rate. Early elective surgery prevents permanent cartilage damage caused by prolonged vascular compression. The surgery is low risk and ensures excellent long-term airway growth. Question 8. Persistent symptoms after surgery. An 18-month-old girl underwent double aortic arch division 3 months ago. Currently, Strider is returning with a brassy cough during a viral illness. Bronchoscopy shows significant tracheal collapse during inspiration below the previous compression site. What is the underlying pathophysiologic explanation? Option A, incomplete ring division. Option B, surgical error. Option C, abnormal cartilage development from prolonged prior compression. Option D, new complete cartilaginous ring formation. The correct answer is option C, abnormal cartilage development from prolonged prior compression. Tracheomalacia is the most common residual postoperative problem. Division of the ring removes the external force, but does not immediately restore tracheal structure. Symptoms typically improve gradually over 1 to 2 years as the child grows and cartilage matures. Question 9. Comoral diverticulum. An 8-month-old boy presents with progressive dysphagia and solid food refusal. Imaging reveals a right arch with a left subclavian artery and a large diverticulum. What is the clinical significance of comoral diverticulum? Option A, fetal ductus remnant with no clinical significance. Option B, aortic diverticulum at left subclavian artery origin contributing to compression. Option C, requires observation only. Option D, indicates surgical decompression is impossible. The correct answer is option B, aortic diverticulum at left subclavian artery origin contributing to compression. It is a remnant of the left fourth aortic arch present in 60% of these cases. It significantly contributes to posterior esophageal compression and should be surgically resected to prevent aneurysm formation later in life. Question 10. Severe combined airway obstruction. A 6-month-old infant presents with severe stridor, respiratory distress, and cyanosis requiring an emergency tracheostomy. Findings include complete cartilaginous tracheal rings and a pulmonary artery sling. What is the clinical significance of this combination? Option A, unrelated to sling. Option B, tracheal stenosis resolves once sling corrected. Option C, concurrent complete rings require additional intervention like tracheoplasty. Option D, emergency tracheostomy is contraindicated. The correct answer is option C, concurrent complete cartilaginous rings require additional intervention like tracheoplasty. Complete tracheal rings are strongly associated with pulmonary artery slings, creating a severe double obstruction mechanism. Sling correction alone will not resolve the internal fixed stenosis, so a staged repair involving a slide tracheoplasty is mandatory. Question 11. Growth failure and dysphagia. An 11-month-old infant has dropped to the 3rd percentile for weight. The infant chokes with solids and has recurrent infections. Imaging shows a right arch with posterior esophageal indentation. How does the vascular ring contribute to failure to thrive? Option A, genetic syndrome. Option B, Esophageal compression impairs swallowing and reduces intake. Option C. Respiratory symptoms prevent exercise. Option D. Associated cardiac defects. The correct answer is option B. Esophageal compression impairs swallowing and reduces intake. Esophageal compression directly restricts solid food intake, while feeding difficulties compound the problem. Furthermore, recurrent infections and chronic respiratory effort massively increase metabolic and caloric needs, leading to progressive growth failure. Postoperative catch-up growth is typical. Question 12. Echocardiographic diagnosis hint. A 5-month-old girl has increasing stridor and a honking cough. An echocardiogram shows the left pulmonary artery arising from the right pulmonary artery. What additional finding would you expect on computed tomography angiography? Option A. Bilateral aortic arch. Option B. Left pulmonary artery coursing between trachea and esophagus. Option C. Innominate artery with leftward origin. Option D. Right arch with retroesophageal left subclavian. The correct answer is option B. Left pulmonary artery coursing between trachea and esophagus. While echocardiography provides the initial diagnostic hint of the anomalous origin, computed tomography or magnetic resonance imaging is strictly required to confirm the complete anatomical picture. This cross-sectional imaging defines the precise surgical approach needed. Question 13. DeGeorge syndrome manifestations. A patient has tetralogy of Fallot, severe coarctation, stridor, and a submucosal cleft palate. Testing confirms a 22q11 deletion. This patient's vascular ring and cardiac anomalies are explained by which of the following? Option A. Random association. Option B. 22q11 deletion syndrome affecting mural crest migration. Option C. Down syndrome. Option D. Familial hereditary pattern. The correct answer is option B. 22q11 deletion syndrome affecting mural crest cell migration. This is the most common genetic association with vascular rings, present in 10 to 20% of patients. It causes multi-system involvement including cardiac, immune, palatal, and renal anomalies, requiring comprehensive multidisciplinary evaluation. Question 14. Croup refractory to therapy. A 7-month-old boy has his third croup-like illness in 2 months, completely unresponsive to dexamethasone and racemic epinephrine. He has baseline stridor and a widened superior mediastinum. What imaging study should be ordered to identify the underlying cause? Option A. Barium esophagography. Option B. Computed tomography or magnetic resonance angiography. Option C. Laryngoscopy. Option D. Echocardiography. The correct answer is option B. Computed tomography or magnetic resonance angiography for vascular ring assessment. Mechanical obstruction from a vascular ring does not respond to anti-inflammatory therapy like steroids. Recurrent episodes, baseline stridor between illnesses, and mediastinal widening on a chest radiograph are major diagnostic red flags pointing toward a structural anomaly. Question 15. Right-sided pulmonary findings. A 10-month-old boy has a persistent dry cough and recurrent right-sided pneumonia. Examination shows decreased breath sounds at the right base. Computed tomography shows a left pulmonary artery sling. Why does the patient have predominantly right-sided findings? Option A. Right bronchus compressed externally by anomalous artery. Option B. Right aortic arch unrelated. Option C. Left lung shunted away. Option D. Complete cartilaginous right bronchus rings. The correct answer is option A. Right bronchus compressed externally by the anomalous left pulmonary artery. The anomalous artery arises from the right pulmonary artery and courses right to left, directly compressing the right mainstem bronchus. This unique compression pattern creates selective right-sided findings like pneumonia and atelectasis. Question 16. Rare combined anomalies. A 4-month-old girl has severe stridor and respiratory distress. Findings include a double aortic arch, pulmonary artery sling, and complete tracheal rings, creating multiple mechanisms of compression. What is the appropriate surgical strategy? Option A. Emergency tracheostomy, then staged comprehensive interventions. Option B. Medical management only. Option C. Divide double arch only. Option D. Tracheostomy alone sufficient. The correct answer is option A. Emergency tracheostomy, then staged comprehensive interventions. This is a rare but severe combination requiring a highly skilled multidisciplinary team. A staged approach avoids overwhelming the delicate neonatal airway. Initial stabilization with a tracheostomy is often life-saving, followed by sequential anatomical corrections, including arch division and tracheoplasty. Understanding the pathophysiology is critical. Encircling vascular structures narrow the trachea, creating turbulent airflow and stridor. Retroesophageal vessels cause posterior esophageal compression, impairing the passage of solid foods and causing severe dysphagia. Furthermore, prolonged vascular compression leads to tracheomalacia, where abnormal cartilage development results in persistent airway collapse even after successful surgical division. During physical examination, listen carefully for inspiratory or biphasic stridor, which indicates the level of compression. Observe the general appearance for growth failure, and note specific feeding behaviors, such as solid food refusal or head hyperextension, to relieve compression. Finally, a thorough cardiovascular assessment must check for murmurs indicating associated congenital heart defects. For diagnostic investigations, a chest radiograph may show a widened mediastinum or tracheal deviation. While barium swallows are excellent for evaluating functional swallowing, computed tomography or magnetic resonance angiography remain the definitive gold standard. These provide rapid, high-resolution, three-dimensional imaging that is absolutely essential for comprehensive surgical planning. Surgical management is indicated for symptomatic respiratory or gastrointestinal compromise, failure to thrive, or recurrent infections. Approaches vary by the specific ring type. For example, a double aortic arch requires division of the smaller arch. Early surgical intervention is crucial to prevent permanent tracheal cartilage damage and to ensure optimal airway growth and development. Postoperative challenges often include persistent tracheomalacia, which is the most common residual problem requiring time to gradually improve as the child's cartilage matures. While surgical risks exist, the long-term prognosis is generally excellent. 85 to 95% of patients experience complete symptom resolution and exhibit significant catch-up growth within a year. Welcome to our Patreon community, Pediatric Case Review. This community contains all videos perfectly arranged by system, so you can easily access everything in one place. All presentations used in our videos are also available as high-quality photos, so you can read and practice all questions at your own pace. For details and how to subscribe, please comment below in this post, and we will message you. In conclusion, early recognition and advanced imaging of vascular rings are crucial for preventing long-term airway damage. We hope this comprehensive review has enhanced your clinical understanding. Please follow our Pediatric Case Review channel for more informative presentations. If you have any questions or need further clarification, drop a comment below. Thank you for watching, and we will see you in the next video.